it secretes one hormone called gonadotropin-releasing hormone. And the gonadotropin-releasing hormone stimulates the anterior pituitary gland. As a result, there is LH and FSH. This LH and FSH will stimulate the ovary, which secretes estrogen and progesterone. This estrogen will, okay, so which cells of the ovary secretes estrogen? The granulosa cells, right? Granulosa cells secretes estrogen, and corpus luteum secretes progesterone, right? So this estrogen will, what they will do, the estrogen will, they will proliferate the endometrium, and the progesterone will maintain the endometrium. And when the progesterone level goes down, there is menstruation, right? So when the progesterone level goes down, there is menstruation. In nutshell, estrogen level is high in the first 14 days, goes down, and progesterone level remains low in the first 14 days, and then it goes high. And when the progesterone level goes down, there occurs menstruation, right? So this is the menstrual cycle in a flowchart, right? So today we are going to understand some of the terms, okay? Some of the terms that are related to menstrual cycle. Okay, so what are the terms that are related to menstrual? To begin with, menstrual cycle, we know that menstrual cycle, it has got, again, 5 days of periods, and then on 14th day there is ovulation, and then there is a 28 day, after 28 days there is again menstruation. So menstruation cycle is a 28 days cycle, right? So, and this is called proliferative phase, and this is called secretory phase. Okay, so why proliferative phase? Because the functional layer of the endometrium, it grows along with blood vessels. There will be blood vessels which have become corkscrew shape, and there will be glands which will become big. So this is the estrogen phase, this is the progesterone phase. So a normal menstrual cycle is a 28-day cycle. It is a 28-day cycle, right? With a estrogen phase and a progesterone phase, or with a proliferative phase or secretory phase, right? And the normal blood that is lost in menstruation is around 40 to 50 ml. So average, usually we don't find 28 days because it's not so normal to be for every female to be in 28 days. So we make an average that is of 21 to 5 days. So the average for normal menstrual cycle is 21 to 35 days with a loss of 40 to 50 ml of blood every month. So there is bleeding of 40 to 50 ml of blood every month, right? So today we'll understand some terms now. Now first term is, what is oligomenorrhea? Oligomenorrhea. The oligomenorrhea oligo means delayed or less. So when this menstrual period is more than 35 days, okay, that is, in a year there is less than 9 menses in a year, per year. Okay, so when the period of menstrual cycle is more than 35 days, then it called this term as a oligomenorrhea. Okay, means when there is a period is increased, oligomenorrhea. So contrast to that, in support to that, there is another term called polymenorrhea. Okay, so when the menstruation cycle is less than 21 days, means the period is increased. Okay, less than 21 days, we call it polymenorrhea. Okay, so when the menstrual cycle is more than 35 days, we call it oligo. When the menstrual cycle is less than 21, we call poly. So polymenorrhea, oligomenorrhea, both are just opposite to each other. Okay, the next term is menorrhagia. Menorrhagia. So menorrhagia means regular but heavy. Regular, the cycle is regular, but there is excessive bleeding. Excessive bleeding. Okay, so there is regular but excessive bleeding. That is more than 80 ml per menstruation, which stays for more than around 7 days. Okay, it is more than 80 ml plus it is more than excess of 7 days. It stays for around 7 days. So then you call the term as a menorrhagia. Now you see there is lots of blood loss and also there is lots of bleeding. That is more than 7 days. Okay, so that term is called menorrhagia. We'll come in details. I'm just giving the terminology first. Okay, so menorrhagia. Next is metrorrhagia. Metrorrhagia. So difference is that in menorrhagia this is regular but excessive bleeding. Metrorrhagia is irregular bleeding. Irregular bleeding, when the bleeding is occurring between the menses, between two menses, when there is bleeding is occurring, then we call it metrorrhagia. So this is a irregular bleeding between the menses. So that is metrorrhagia. Then number 5 terminology is dysmenorrhea. Dysmenorrhea. When this menstruation is associated with pain, it's so painful that it is affecting the quality of her life. It is so painful when her daily activities are going down, when she cannot perform her day-to-day activities. Okay, then we call it a dysmenorrhea. So painful menstruation. Painful menstruation. We call it dysmenorrhea. We'll discuss in detail, don't worry. And number 6 term related to menstrual cycle is amenorrhea. Amenorrhea. So amenorrhea means no menstruation. Amenorrhea means no menstruation. Okay, so these are the 6 terms that are related to menstrual cycles, and you need to understand these 6 terms. Okay, so we'll go one by one. So first we'll deal with amenorrhea. So amenorrhea means no menstruation. When the menstruation is missed, we call it amenorrhea. Now amenorrhea can be primary. It can be these are amenorrhea is 2 types: primary and secondary. Primary and secondary. Now primary means when there is no pathology. Okay, when someone is not menstruating since birth, means normally puberty is around 13 to 14 years of age or 15 years of age. When somebody is not menstruating, even if she has crossed 15, 16, and there is no underlying and means she has never menstruated before, then we put her in a category of primary amenorrhea. Then we put it in primary amenorrhea. Okay, when there is no menarche. Menarche means start of menstruation. When there is no menarche, by age 14, by when she has reached 14 years of age, but still menarche has not developed. Still she has not menstruated. Okay, plus there is no development, no pubertal development. So no pubertal development, she has not menstruated. Also her breast is not developed. She has not developed any hairs. Even there is no pubic hairs. Uterus has not developed. So all those developments is also absent. and she has also not menstruated. That is also one type of primary amenorrhea. Another type of primary amenorrhea is that when someone is having all the pubertal development is okay, so there is pubertal development. There is pubertal development, but she has not menstruated yet. She has not no menses till 15 years of age. No menses till 15 years of age. So she has reached 15 years. She has all the pubertal development, all the necessary sexual characteristics, secondary sexual characteristics, everything is developed fine, but she has not just having menses. So that is a different second type of primary amenorrhea. Okay, that is the second type of primary amenorrhea. So one type and two type. Now how does it result in amenorrhea? How there is amenorrhea? Okay, we'll understand this fact now. So to understand this fact, you have to know one thing, that is HPO axis. We already discussed it many times. The hypothalamus, we know it releases gonadotropin-releasing hormone from hypothalamus. It will stimulate pituitary gland to secrete LH and FSH, which secretes ovaries, stimulate the ovaries to secrete what? Estrogen and progesterone. So this is a HPO axis. Okay, means hypothalamus. Okay, here hypothalamus, pituitary gland and ovaries. So there is the axis. It releases gonadotropin-releasing hormone. It releases LH and FSH, and ovaries release estrogen and progesterone. So everything is linked. So if due to some condition this hypothalamus is not releasing gonadotropin hormone, as a result pituitary gland is not releasing FSH and LH, as a result ovaries are not secreting estrogen and progesterone, then also there will be no menarche. So menstruation will not start. So this is called downward. There is the HPO axis is downed. It is shut down. Okay, so we call that hypogonadotropin. Hypogonadism. It's called hypogonadotropin. This is a hypogonadotropin phenomenon. Okay, hypogonadotropic. It is the hypogonadotropic. As a result, ovaries are also down. So, because of ovaries are not working well, so ovaries are down because of less stimulation. So, hypogonadotropic. This part is hypogonadotropic, and ovaries are also down. So, hypogonadism. Hypogonadism. This is one way there can be amenorrhea. And in some females, hormones are secreting well, gonadotropin hormone is secreted well, LH and FSH are secreting well, but ovaries are not responding. Ovaries are insensitive. Ovaries are insensitive to FSH and LH. As a result, they are secreting less than estrogen and progesterone. So in that case, we will say when these are in excess, means GnRH is in excess, FSH and LH are in excess, but ovaries are not responding to them. In that case, we will say that this is a hypergonadotropin, because GnRH is in excess, hypergonadotropin, hypogonadism. So that's the difference, okay? Hypergonadotropin, hypogonadism. So this is because of ovarian insensitivity. It is because of ovarian insensitivity. So a person can have primary amenorrhea either because a person can have primary amenorrhea either because of hypergonadotropin, just ovarian insensitive. This is the case of ovarian insensitive, hypergonadotropin, but ovaries are down, hypogonadism. Or a person can have hypogonadotropin and hypogonadism. When ovaries are, everything is shut down. Here ovaries are normal, but hypothalamus is not secreting enough gonadotropin-releasing hormone. Okay, so these are the two causes where a female can have amenorrhea. Amenorrhea means no menstruation. She has not yet gained the status of menarche. She has not yet started the menstruation. okay, which can be either she fall in this category or this category. Again, either she can have pubertal development or she can have no pubertal development. Okay, so amenorrhea can be of various causes. It's a multifactorial. Apart from that, what are the other causes that can have amenorrhea? Any sort of like poor diet. Okay, so poor diet, nutrition, emotional status, it also relates to amenorrhea. So now we will go into the secondary causes of amenorrhea. What are the secondary causes? Secondary causes of amenorrhea means what? Means she was menstruating before, but now she is having no menstruation. So no menstruation since 6 months, 6 period. When someone has missed 6 periods of her menstruation life, consecutive 6 periods of her menstruating life, okay, then we call it secondary amenorrhea. Secondary amenorrhea. So this is the group of people who are menstruating before. Okay, there is no problem in menarche. There is no problem in the starting of menstruation. She was menstruating before, but she has missed 6 periods, consecutive 6 periods. Okay, then she falls in secondary amenorrhea, and the best example is pregnancy. In pregnancy, there is no menstruation. So best cause of secondary amenorrhea, which is the most commonest cause of secondary amenorrhea. If it comes in the exam, you will take the pregnancy is the most common. Now it's not necessary everyone is pregnant when someone is having. What are the other causes of secondary amenorrhea? Excessive exercise, stress, poor nutrition can lead to missed periods. It can lead to when someone is very lean and thin, okay, when someone is not having good nutrition, malnourished, lot of stress, and excessive exercise. When someone is doing excessive exercise in the gyms, excessive workout, it can also lead to missed period. Okay, that is also one of the causes of secondary amenorrhea. Other than that, what are the other causes? Any sort of anatomical defect can also result in amenorrhea. Basically, anatomical defect will result in primary amenorrhea. Like genetical defect, there is some genetical defect. There is the uterus is absent or imperforate hymen. When hymen is not perforated, imperforate hymen, or absence of uterus. So this is the case of primary amenorrhea. There is some anatomical defect. So overall, causes of primary amenorrhea, secondary amenorrhea are, apart from pregnancy, there is some. It may be some because of some genetic defect. Okay, like Kallman syndromes, Turner syndromes. Okay, when there is the chromosomal disorders. Okay, genetic defect. Then endocrinal disorders. Endocrine, especially because of hypothyroidism. Endocrinal. Then nutritional status or anatomical defect. Anatomical defect. So we call that GENA. Okay. So G for genetic defect, E for endocrinal, N for nutritional, A for anatomical. Anatomical defect like absence of uterus or hymen is imperforate. There is some genetical defect. Okay. So endocrinal, like hypothyroidism is one cause. When the thyroid hormone is very low, there may be a missed period. Okay. And nutritional factors is very important. Apart from that, as I discussed with you, stress, over exercise. These are all the factors that regulates menstrual cycle, and also family history. Sometimes it runs in the family. Okay, so we should take a very careful history when we are dealing with someone with cases of amenorrhea. Though the commonest cause is pregnancy, but it's not necessary everyone is pregnant when someone is just missing her period. So family history is also important. Sometimes it runs in the families. Okay, the whole branch of the family, they are having some problems with menstruation. Okay, it runs in the families. So endocrinal, we have to check all the hormones, LH, FSH, then progesterone, estrogen, every hormone should be studied in details. Nutritional factors should be studied, to be analyzed, and anatomical defects should be excluded by doing ultrasound or CT scan. Okay, so these are the cases of amenorrhea. Now we are going to the next part. What is dysmenorrhea? Dysmenorrhea. So as the name suggests, dysmenorrhea is the painful cramps. Painful cramps. Painful cramps, mostly in the lower abdomen. Lower abdomen. Often going to the back. Often going to the back. Lower abdomen, often going to the back. Okay. So painful menstruation. The menstruation is so painful that it makes her unable to do her normal daily household chores. Normal day-to-day activities are not possible. So understandably, it impacts the quality of her life. Okay. So then we call dysmenorrhea. It's not that she's having pain and she's doing all activities. No, that's not dysmenorrhea. So the pain is so much that she's unable to do her daily activities. Then you term it as a dysmenorrhea. Okay. Again, the dysmenorrhea is in two types. One is called primary. Another is called secondary. Okay. So primary and secondary. So what else you'll find in dysmenorrhea when you get a patient? Obviously there will be painful cramps, lower abdomen, mostly in lower abdomen, going to the back. But don't forget there is another thing, that is vomiting. It is associated with, most of the times it is associated with vomiting. Okay. So let's go what are primary, what are secondary. So primary is more common in adults or young people. So when you say dysmenorrhea, primary dysmenorrhea is that when there is all the dysmenorrhea signs and symptoms will be there, like pain abdomen, going to the back, vomiting, all those. But when you will scan it, when you will do an ultrasound, when you will examine, there is no underlying pathology. So primary dysmenorrhea means all the dysmenorrhea symptoms plus no underlying pathology. Underlying pathology. No underlying pathology. So this type of dysmenorrhea mostly occurs in nullipara. Nullipara means pregnancy or children. So there is no children. They don't have any kids. No children. Those women don't have children, or they are not married. You can say they don't have any children, or they have never been pregnant before. Okay, this falls in. These are those women when you do an ultrasound CT scan. There is no underlying pathology. So we don't know the exact cause why the dysmenorrhea develops, and they are mostly adults or young people. Okay, and what happens? And also the pain that develops, we call it a spasmodic pain. Spasmodic. Spasm means now this is a tube. When this tube spasm means the pain, it is because of the spasmodic. It becomes spasm means narrowed. It becomes narrowed. Okay, so spasmodic means this type of pain. So like intestinal pains, when there is a pain abdomen because of intestine or gallbladder, they close it. There is spasm. We call spasmodic pain. The pain comes because of spasm, and then after the pain goes off. After again sometime pain comes because of the spasm of the gallbladder or the intestine. All those gallbladder pain, intestinal pain, this in primary dysmenorrhea also, the pain is just like that. It's spasmodic. In the lower abdomen, the pain will the cramp will be like this coming up. It's very, very severe, and after some time it will relieve. Okay, that is called spasmodic. So this spasmodic pain, it basically starts during the time of menstruation or before menstruation and lasts throughout. Okay, it's basically during the time of it means what I'm trying to say, primary dysmenorrhea, spasmodic pain. What type of spasmodic pain? It's also called colicky pain. Colicky, like the colon, when there is a pain in the large intestine, the colicky pain, and it starts with menses, with menstruation. It starts with menstruation and lasts throughout the menstruation. Lasts throughout the menstruation. It starts with menstruation or just before. It starts with menstruation at the time of menstruation or just before. So this is so severe pain. It stays for some time and then goes. Again stays for some time, again it goes. So that's why it's called spasmodic pain. So we are discussing primary dysmenorrhea. It is more common in young people, and there is no underlying pathology. There is no pathology, and it is colicky type of pain, mostly found in nullipara, in those who have no kids, no children, not married, young people, and it starts its menstruation and lasts throughout the menstrual period. These are type of primary dysmenorrhea. They fall into the primary dysmenorrhea type of pain. Now, what is the pathophysiology? Why there is pain? Okay. Now, again, we have to understand the HPO axis. We know gonadotropin-releasing hormone, right? It stimulates anterior pituitary gland, secretes LH, secretes FSH, right? So LH will see, FSH will go through ovary and to secrete progesterone and estrogen, right? So when the progesterone level goes down, we know what happens. The layer of the endometrium sloughs away. So let's say this is the part of the functionalist layer of the endometrium. So endometrium has two layers, you know, functional layer and basal layer. So let's say this is the functionalist layer. Okay, and there is these blood vessels which are grooming and becoming, as it's more and more thicker, it's becoming very, very corkscrew shaped. Corkscrew is coiled. Okay. Now when the progesterone level goes down, we know this whole layer being shed off. So when this whole layer being shed off, so let's say this layer is shed off. Now what happens to these blood vessels? These blood vessels are just hanging out there. They're half-cut blood vessels. Okay. Now and lots of tissues are being damaged. So when this tissues is lost, remember there's one thing that is secreted here is because of prostaglandins. Prostaglandins. So there is enough PGF2 is made here. Enough PGF2, prostaglandins F2, PGF2 is made here. Where because by the damaged tissues or destroyed tissues during menstruation. So this prostaglandin F2, what does it normally do? It makes the uterus contracts. It contracts the uterus. So in some unfortunate people, there is lots and lots of PGF2 is secreted. It is secreted in a high amount. So as a result, the uterus, the whole uterus, it contracts because it contracts the uterus. So because of the whole uterus contracts, it gives a pain. Okay, this uterus contracts. Now why there is? Now the question comes that why there is pain if the uterus contracts? Now listen, the anatomically. Now suppose this uterus is there. Okay, this is the uterus. It's a bag of uterus. The blood vessels are like this. The blood vessels travel through the uterus like this. So when the uterus contracts, means it's becoming smaller, right? When the uterus contracts, it is also compressing the blood vessels present inside. So when you are compressing the blood vessels, right? So these are the blood vessels. So when the uterus is contracting, when the whole uterus is contracting, so as a result, what will happen? During every contraction, these blood vessels will be also compressed. So there will be no blood supply. The blood, during every contraction, blood supply is cut down. Right? So during every contraction, the blood supply is cut down. So suppose this blood vessel is supplying the blood to this part of the uterus. This is supplying to this part of the uterus. This is supplying blood to this part of the uterus. Means what? Every time the uterus contracts, you are cutting off the blood supply. You are cutting the blood supply. Means these tissues of uterus, they go in a state of infarction. They goes in a state of angina, just like MI. So every time there is a contraction, these tissues are getting no blood supply. Means no oxygen supply. So same like in MI, what happens in myocardial infarctions when there is a coronary artery is blocked because of atherosclerosis, that part don't get blood supply, means no oxygen supply. As a result, that part of the heart, it cries of pain, what is called angina, what is called chest pain. So same thing. So every time the uterus contracts, because blood vessels are like this. So every time the uterus contracts, it compresses the blood vessels. So uterus goes in a state of angina. Okay, and the uterus cries of pain. That's why there is pain even in pregnancy. What happens? Pregnancy, there is pain during contraction, during the time of delivery. Why there is pain? Because uterus contracting hard. Uterus contracting hard, all is compressing all the blood vessels. Every time you are compressing the blood vessel, this area will be not getting blood supply. For a few seconds, these areas are not getting any blood. So when it will not get blood, it will be pain. Why? Because it's not getting blood, because it will producing PGF2. Because lots and lots of this PGF2, prostaglandins F2, we know that this PGF2, when it is secreted, we know it stimulates the lateral spinothalamic tract and it can cause pain. So that is the concept. So every time after this HPA axis is stimulated and progesterone goes down, there is menstruation, there is lots of tissues are sloughed away, lots and lots of blood vessels are damaged, sloughed away from the middle. So these are hanging blood vessels during menstruation. So there are some damaged tissues, lots of PGF2 is secreted. This PGF2 is again now stimulating the uterine contraction. So uterus is contracting hard because uterus wants to remove all those dead cells. Uterus wants to remove the dead blood vessel, dead cells that is producing during menstruation. Uterus wants to get rid of that extra layer. So uterus is contracting hard. So because of the contracting hard, the blood vessels are being compressed. So when these blood vessels are being compressed and the area distal to that area in that particular uterus is then going to a situation like angina, is crying of pain. That's why there is painful contractions. So in some cases in menstruation there is more and more release of PGF2, more uterine contractions and more pain. Okay, but when you ultrasound or you are doing some X-ray, you are doing all the investigation, you are not finding any pathology. So when it happens like that, then we call primary dysmenorrhea. So then we call it primary dysmenorrhea. So all the dysmenorrhea symptoms are there, signs and symptoms, but there is no underlying pathology. Okay. Now going to the secondary. When there is a dysmenorrhea case, dysmenorrhea, and there is also underlying pathology, then we call it secondary dysmenorrhea. Secondary dysmenorrhea. So there are all the dysmenorrhea signs and symptoms like cramps, lower abdominal pain, going to the back, vomiting. Okay. Plus you did a scan or investigation, you find some underlying pathology, then it's called as secondary dysmenorrhea. So secondary dysmenorrhea most commonly occurs in the other extreme, not in the young people. In most commonly it is common old, not around 50 years of age. Around 50 years of age. Okay. And in secondary dysmenorrhea, the pain is not spasmodic. Okay. It is a different type of pain. You know, it is a what is called. We call it a congestive pain. The pain is congestive. So the pain often starts few days before mens. Few days before mens. So few days before mens, and it is most of the time it is intensified. It increases. 50% cases it increases during menstruation, and 50% cases it remains constant. But thing is that it is not like spasmodic. It is a severe pain, but the thing is that it starts few days before menstruation. Okay. So what I am going to tell you here, if someone is having few days before, pain is coming few days before starting of mens, then she is having secondary. Secondary is always there is underlying pathology. There is some underlying pathology. What are the underlying pathology that can cause painful menstruations? Any sort of polyp. Okay. So this is the uterus, and from the myometrium there sometimes this is called polyps. Polyps are hanging. So polyps can be there. There can be adenomyosis. We'll discuss this adenomyosis later on when there is the growth of the myometrium. Okay, then there is some structural deformity like myoma, fibroid. When there is the myometrium, there is a growth of tumor. There is a growth here in the myometrium. We call it as a fibroid. Fibroid. When there is a growth in the myometrium, not in endometrium. And there is any sort of cancer, malignancy. So they are reasons of secondary dysmenorrhea. Okay, they are the reasons of secondary dysmenorrhea. When there is any sort of cancers, any sort of fibroid, structural deformity. There is sometimes what we call overgrowth of the endometrial tissues or overexposure of the endometrium to estrogen. Okay. Now listen. Now try to understand this thing. We know when there is in the 0 days, 14 days, 28 days. Okay. We know this in this period estrogen is high. What does estrogen do? Is the estrogen in the uterus, estrogen will proliferate the endometrium. Endometrium grows beautifully. It grows under the influence of estrogen. So when in the 14 days, the endometrium grows. Which layer of the endometrium grows? The functional layer of the endometrium grows. Right? Now suppose she is not having menstruation. Okay, suppose she is not having menstruation, it means she is overexposed to endometrium. Last 3-4 months she is not having menstruation. So what happens? This endometrium, this will grow more, right? This will grow more because she is still not sculpted. So layer is now piled up, more and more layer. So overgrowth, because of overexposure of estrogen, she can have overgrowth of endometrial layer, which can result of this type of things when the endometrium is growing big and now causing pain. So these are the things. So what I'm trying to tell you, that pain during menstruation or at the start of menstruation is mostly primary. Primary is a good thing. There is no pathology there. Okay. Pain 2 days, 3 days before menstruation, though it's not found in young people, it's mostly found in 50+ aged people. Okay. That's not a good news because most of the time there is maybe a tumor, maybe a fibroid, maybe a polyp, many things can occur. But that is a secondary dysmenorrhea. Okay. And what is the pathophysiology of dysmenorrhea? It is because of prostaglandins, which is making the uterine contraction, which is increasing the uterine contraction. As a result, blood vessels are occluded. As a result, there is a state of angina in the uterus muscle. So there is pain, right? So that is about dysmenorrhea. So treatment is obviously we give painkillers, NSAID. We give in primary cases NSAID. These are painkillers like Brufen, naproxen. These are NSAID group of painkillers which are given in primary. And secondary, according to you have to do an ultrasound scan, find out the fibroma or any malignancy or anything, then you have to remove it. Okay, that's the treatment. So treatment is mostly NSAID. These are the painkillers, non-steroid anti-inflammatory drug. Okay, NSAID group of drugs. You'll be taught in pharmacology. Non-steroidal anti-inflammatory drugs, NSAID group of drugs, like Brufen. Okay. So I'm going to the now next part. Next is the Menorrhagia. So Menorrhagia means heavy menstrual bleeding. That is more than 80 ml. Lasting for around or more than 7 days. Okay. So more than 80 ml blood is lost, lasting for more than or equal to 7 days. And this bleeding is so high that it can also lead affecting her day-to-day activities. So that is Menorrhagia. Okay, there is a Menorrhagia. So causes are, what are the causes that can cause more bleeding? What are the causes? It can be because of any sort of infections in pelvic inflammatory disease. When there is any infection in the pelvis, it may be STD or any pelvic inflammatory disease. It can then any sort of, again, endometriosis. Okay. Now I'll just give you a quick view of endometriosis. It's a very common term and it's one of the common terms when a person bleeds more. Okay, but I'll not go in detail because you'll be taught in next year, in year 3. Now due to some problems, okay, the endometrial tissue. Now we know there is a layer of endometrium. This is the innermost layer is called endometrium. Right? Now due to some unknown etiology, sometimes there is ectopic. Ectopic means when it is not in the normal place. Ectopic, when it is present where it's not supposed to be. So sometimes endometrium, they are present also over in the ovaries. There's some ectopic endometrial tissue. Ectopic endometrial tissue, where near in the ovaries. Ectopic endometrial, it can be anywhere. Like this endometrium, ectopic endometrial tissues. Ectopic endometrial tissues, it can be anywhere. Okay, when there is endometriosis, we call endometriosis. When there is this layer of endometrium is not only present in uterus, it is also present in the fallopian tubes, also present in the ovary somewhere. Now, like every month, endometrium, the functional layer of endometrium bleed, right? It goes sloughed off. So, endometrium grows because of hormones. Endometrium grows because of estrogen. So, every month she is having before 14 days, so 0, 14, 28, estrogen is high before 14 days. So, before 14 days, this estrogen present outside the uterus, it will also grow. This endometrial tissue will also grow. Not only here, it will also here, because they are all under influence of estrogen. And at the end of the 28 days, when progesterone goes down, this will also slough. This will be also going down. This will be also down. You understand? So not only this will go down, this will also slough up. This will also slough. So there is excessive bleeding. So it is also one of the common cause in young women. When there is endometriosis. Endometriosis means ectopic endometrial tissue. So if there is ectopic endometrial tissue here, so with every month, not only this endometrium will proliferate, they will also proliferate. And at the end of the 28 days, they will bleed, this will also bleed. So overall there is a heavy bleeding. So endometriosis is one of the cause of menorrhagia. And it is very commonly found in young people. And what else? And any sort of structural deformity like fibroid, as I discussed, all those etiologies are same. So we say it is a causes, we say it is like this. Palm. Okay. Any sort of polyp, these are called polyps. Any sort of adenomyosis, like endometriosis, adenomyosis. Any sort of leiomyoma, we say leiomyoma means fibroid. And malignancy, cancers. So these are result on menorrhagia. Other than what are the other causes? Any sort of bleeding disorders. If she has any bleeding disorders, this can also, and hyperthyroidism. When there is a thyroid hormone is also imbalance, they can also bleed. Hyperthyroidism or bleeding disorders, they can also have menorrhagia. So menorrhagia means excessive blood, more than 80 ml, lasting for more than 7 days. So these are the causes for menorrhagia. Do you have any questions? You can ask me now. Okay. So related to menstrual cycle, there is dysmenorrhea, this is painful. There is menorrhagia, and there is amenorrhea.